We're going to talk about the actual appliance or the principles of parafunctional control that you can do with a wad of acrylic or a suck-down piece of plastic. You can make with a prefabricated device, but the principles remain the same regardless on how you manufacture this device. You know, I'm sort of brainwashed because I started doing this when I didn't have a whole lot of other stuff to do. So I always made my own in the lab, and I was bending wires a lot of the time. I can't imagine having the time to bend wires if you're a practicing dentist. So now I'm in a situation in a neurology clinic where I'm expected within a half an hour to have the patient leave with a parafunctional control device. So I use thermoplastic beads. I don't know if you get examples of those now, but it's a thermoplastic material and a prefabricated shell, an electric handpiece, and I can do it. About 85% or more of the time, I can finish a device in that amount of time. There's not a whole lot of variations that I can't tackle with that armamentaria, but that's all I do. I have nothing else to think about. In a regular general dentistry practice, a lot of times you discover this patient is a candidate for parafunctional control at the end of their hygiene visit. So now what do? Come back in 2 weeks and I'll make you one because I'll have time, or take an impression right now, send it off to the Keller lab. They're a licensed lab to make this whole concept, and they come back in 2 weeks and away you go. Regardless of what you're delivering or what you've devised yourself, the principles of the protocol remain the same.
Do you like the thermoplastic better?
I like the thermoplastic better than the smell of the acrylic in a neurology clinic, that's for sure. I like the thermoplastic if I'm going to retain on lower incisors and do a direct chair side. I like it better than acrylic.
I don't.
So there you go. Now I'll bet you that, like on Wednesday, I made 6 of them in 3 hours. And I do them a lot, and that's all I do, and I can get them to be just right. And I could use acrylic to be just right. It takes me longer with the acrylic. And I've got to make sure on lower incisors, I better get that thing out at 2 minutes. And when those things are crooked and twisted, I better start trimming down internally right now, because the harder it gets, the duller my scalpel's getting. And I hate having to change the scalpel. With that thermoplastic, if I see they're really crooked, I can actually do that. And then take it out and throw it in cold water, and it goes plunk, and it comes back out. With acrylic, I don't have that luxury. I'll show some examples with thermoplastic. I can extend around the arch right now and obtain retention that I couldn't do as readily with acrylic. Both have their advantages, and so that's down to arts and crafts. It's what your patient presents you, and you've got these things. Now, I wasn't using the thermoplastic beads forever. I was the hardcore acrylic guy. There's no other way to go. And I had 3 more patients to go at the neurology clinic. I'm out of acrylic. They figure I'm Jim Boyd. I am the NTI guy. And I've got a thing of beads, and it says NTI on the jar. I've never used them before. So I've seen the instructions because I helped sort of write the instructions. So I faked like I knew exactly what I was doing, and I nailed 3 of them in a row. I've never used acrylic since. It was the coolest thing. And I was like, this is so cool. Just boop, 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 boop. Anyway, well, I'll show later how I exploit that opportunity, but there's too many times when you see these devices and you expect the patient to wear it indefinitely. I wish it would have been a Keller device, or I wish my NTI directs with acrylic wouldn't turn so goofy yellow looking. I hate that. For $500.
Yellow snap.
No, it's clear snap, but it's not designed to last 3 years. Clear incisal color snap is designed to be as a temporary crown, not 5 years. But when a patient brings their NTI Plus, Keller Lab makes that, I don't know how old it is, because it doesn't change color. I know if they've had a device made with snap and the thing's like this weird color, it wasn't made last week. It's been there a while. Okay, so the parafunctional control protocol, these principles. You want to reduce maximum clenching intensity, you'll have incisal edge contact. You want to optimize the lateral pterygoid vector in these excursions. And now the contact is on the central. If you can get it as close to the middle as you can, even though the jaw's off to the side, that's where you're trying to aim your target, your force vector from that lateral pterygoid engine. You want to aim at a certain place on the dock, which is right there. When this jaw moves side to side, don't give it any resistance. You don't want it to be gravelly. You want to be as smooth and glassy and as polished as you can make it. In protrusion, you want minimal condylar rotation. So when they protrude, you see how this slants down? It slants down back here, and if it had been absolutely parallel with the mandibular plane, which ramps up, we'll see in a second here how there would have been too much rotation of opening in protrusion, and that becomes a problem. So the principles of parafunctional control. You have your goal and how you get there. Minimal muscle contraction intensity. In normal masticatory function, you rarely exceed 30% of maximum. You don't really need to get there, and if you do, it's just for that. You break something, just go. You don't get that high anymore. So it's very short durations in excess of 30% of maximum. That's normal function. We want to stay close to what normal purposeful function is all about, because most people have adapted to that. So you stay at that area by staying with an incisal edge contact. We want minimal condylar rotation during these excursions and protrusions. Normally the condyle is not rotated during closure in function. It's the other way around. We want to minimize the vertical dimension of this discluding element no matter where the jaw has arrived at. So essentially, if you want a cookbook, there's just two rules. Incisal edge contact, no matter where the jaw goes, with minimal vertical opening. You want to make the DE as small as you can wherever they go. And I keep saying wherever they go because pretty soon you start to recognize the patient doesn't go anywhere. They're primary clenchers. That's when we're going to turn around in reverse field and monkey with vertical dimension. Every time I delivered a device, and they say, well, how long will this? They have this, I say, I'll tell you, so one of three things is going to happen to you. You're going to get better, or worse, or different. To a patient that's got chronic pain, different is worse, because they were used to this kind of pain, and now they've got this kind. That bugs them, because they don't have the protocol to take care of that new kind of pain. I used to hurt like this, and now I hurt like this. I used to have sinus pain, now I do. I was used to the migraine. So there's going to be they're going to improve or change or not change at all. So one of three things is going to happen. I'll say, if you get better, you will not demand an explanation. No one does. I get to make up why you got better if you get better. I can make it up why. You don't even care. If you get worse, unlike the pills that have been prescribed, if you get worse, you never take those pills again. And no one questions you. No one says they're bad pills, they say they're not the right pills. If you get different or worse with an NTI, it's not a bad NTI, it's not the right NTI. I need to modify that for you because we're in the ballpark. I have irritated the beast. If I can modify your condition with a piece of plastic, and it won't happen as you leave the office, I don't care if you wear it home. You got to go to sleep with it. If you wake up different or worse, at some point you stop wearing it, remember what it was that it was like, and report that back. And like the mechanic who needs to know if it's a clank or a clunk or your description will guide me to what to do. If we monkey with this device a couple of times and there's no change at all, and I can make modifications in you if you don't change, then we're going to rule out what Andy or Dr. Blumenfeld thinks might be going on. And sometimes the ruling out of this most obvious contributory to the bucket, if that's the most obvious, it's been ruled out, at least the pain specialist with that information say, we've had a couple of people that for sure this was going to be a slam dunk. Had all the wake up with a number, You know, the number grows throughout the day, no other obvious signs or blah, blah, blah. I did everything, nothing changed. So Dr. Blumenfeld goes back and reviews the patient and looks at her kind of differently, and went and had a spinal tap done, and she had an elevated cerebral spinal fluid level, pressure. The pressure was too high. So she's taking special medications for that. But as he went back and reviewed it, it all made sense. But if you had diagnosed that at the very, very beginning, that's just weird. First, you want to do what's the most obvious that I can take care of quickly, that doesn't take weeks to discover. We got it. If it doesn't, don't diagnose it, we're back to looking somewhere else.